Target organs. Target organs, parts of the body with special significance to the conflicts or losses in a person's life, are the most likely areas for disease to take root. Persons susceptible to cancer should develop many primary tumors at one time in various parts of the body. Instead, they invariably develop cancer in only one area that is psychologically significant to them, the target organ. I remember one woman in the hospital who gave me a positive statement when I asked her how she visualized her X-ray therapy. She said, "I see it as a golden beam of sunshine entering my body." I told her, "Someone must have been here before me and explained all this to you." She said, "Just the woman in the next bed." A woman with both hands in bandages was lying there. I talked to her and learned that 6 or 7 years before she'd had a mesothelioma, was told she'd be dead in 6 months, made enormous spiritual changes in her life, and the disease had disappeared. I asked, "Why did you need this illness?" And she said, "I don't know." We talked for a while, and she told me she had a lovely husband and 2 beautiful children. But at home, there was no one to talk to about the incredible changes she had made in healing herself. And it was wonderful to be in the hospital. She had all the interns, nurses, and staff to talk to. I said, "Aha, then that's why you're here with your hands wrapped up with these infections." And I said to her, "I'll find people for you to talk to. You go ahead and get well." One of my breast cancer patients was a perfect example, not only of this connection, but also of the hope that comes from realizing the connection. Diana's son had lost his life in a hit-and-run accident, and she was making an enormous effort to track down the killer, since the police had botched the job and ruined the evidence. Her friends kept telling her that she was literally killing herself. She became overweight and developed high blood pressure. Finally came the breast cancer that compounded her despair. As we talked, however, Diana came to realize that her own emotions and actions had contributed to her disease, and that by changing them, she could contribute to her ability to get well. After she left the office, my nurse asked, "Didn't you tell her she has cancer?" "Of course," I replied. "Why?" "Because she was smiling on the way out." Many patients already know something of this link and only require an open-minded doctor to be able to use the knowledge. I was always considered spineless, and here I've developed multiple myeloma of my backbone. Or a woman involved in a stressful love affair with a married man says, "I was afraid I'd get cancer, and I knew if I did, it would be in the cervix." After seeing a man with cancer of the rectum, I asked him what happened in the last year or 2 of his life. He said, "Nothing much." So I asked his daughter. She said she had married out of the family religion and her brother had run away from home. Later, while helping the man explore his attitudes in ECAP, one of the other members said, "That boy must have been some pain in the ass." A multiple sclerosis patient whose household help left her with 5 young children to care for lost the use of her right hand. She had just lost her right-hand man. To an outsider, a connection may sometimes seem far-fetched, but only the patient can finally judge whether it's real or not. Having seen it happen time and time again, I've concluded that we sensitize the target organs of our bodies in a form of negative biofeedback. Psychological profile of cancer. Today, we are able to sketch a fairly complete psychological profile of those people who are most likely to develop cancer. The typical cancer patient, let's say a man, experienced a lack of closeness to his parents during childhood, a lack of the kind of unconditional love that could have assured him of his intrinsic value and ability to overcome challenges. As he grew up, he became strongly extroverted, but not so much from an innate attraction to others as from a dependency on them for validation of his own worth. Adolescence was an even harder time for this future cancer patient than for other teenagers. Difficulty in forming more than superficial friendships led to an excruciating loneliness and reinforcement of earlier feelings of inadequacy. Such a person tends to view himself as stupid, clumsy, weak, and inept at social games or sports, despite real achievements that are often the envy of classmates. At the same time, he may cherish a vision of the real me, who is supremely gifted. But this authentic self is carefully hidden in the belief that it would jeopardize the subjectively minimal acceptance and love that the person has received. He thinks, if I act the way I really feel, childlike, brilliant, loving, and crazy, I'll be rejected. I gave one of my patients, a young woman named Adrian, a copy of Gerald Jambolski's book, Love is Letting Go of Fear. After she'd read it, she told me, I was like this book. I was a flower child, in love with the world, and my parents said, grow up. So I grew up and got cancer. And you walk in and say, become a child. Adrian went back to her authentic, loving self and is well today. Loving doesn't mean one hasn't grown up. Being childlike is not childish. At some time, however, usually in the late teens or early 20s, the patient-to-be falls in love, finds one or two close friends, gets a job that provides real satisfaction, or otherwise reaches some level of happiness based outside the self. He is unable to take any credit for this turn of events. It seems like pure luck, more than he deserves. But for the time being, all is well. Sooner or later, it may be a few years, it may be decades, the external meaning vanishes. The friends move away. The job disappears or becomes less satisfying. The loved spouse leaves or dies. These changes happen to us all, and they are always painful. But to someone who has put all his eggs in one basket, the loss is disabling. Yet it usually doesn't appear to be. Others think he is taking it remarkably well, but inside there is a hollowness. All the old feelings of unworthiness come flooding back, and all feeling of meaning in his life is lost. The routine usually goes on. Having been a compulsive giver since childhood, the future cancer patient continues going through the motions with whoever remains in his life, until depleted and exhausted. Over and over again, I hear friends and relatives say, he was a saint, why him? The truth is that compulsively proper and generous people predominate among cancer patients because they put the needs of others ahead of their own. Cancer might be called the disease of nice people. They are nice by other people's standards, however. They are conditional lovers. They are giving only in order to receive love. If their giving is not rewarded, they are more vulnerable to illness than ever. It's important for a patient to understand the lifelong pattern, but for the immediate purpose, getting well, the problem must be put in terms that can be dealt with now. In most cases, this involves a recognition of conflict. For cancer patients, it usually means finding out how the needs of others, seen as the only ones that count, are used to cover up one's own. Often a real power struggle develops. I saw this most clearly and tragically in the case of Norma, a kneecap member with an abusive husband. Her disease started to disappear as she became more self-caring. Then her husband developed heart disease and was hospitalized. Norma was faced with a choice. Rather than force her husband to choose between growing with her or fostering his illness, she chose to return to her old self. He resumed his abuse and got well, while she went home to die, telling the rest of the group there was to be no funny business. No attempts to change her mind if we came to visit her. Each of us has more or less the same choices. Norma's husband could have learned to love, or she could have asserted herself and gone on to live. But old patterns, though painful, are easier. Change is difficult, uncomfortable, and frightening. That's how we know we're changing. It is often extraordinarily hard for the compulsive giver to stop, to say no, without feeling guilty. Many of my female patients have come to group meetings saying, I'll do anything to get well. Then I outline our program, including time for exercise and meditation, and they say, oh, but then dinner will be late. A patient named Sharon told us her husband's secretary had left, so she had to go in and work for him until he could find a replacement. The trouble was, she hated the job. I told her, you can't survive cancer if you get up every morning thinking how you hate what you'll be doing all day. Still, it took her 2 or 3 months to, as she put it, give her husband notice. When individuals think about saying no, the thing that most often helps them do it is the sense of a time limit in their lives. If you knew you had a day to live, would you spend 3 hours lying in the x-ray department, waiting for a test to be done? Hell no. You'd say, take me back to my room. This is the last 24 hours of my life, and I'm not going to spend 1/8 of it in the x-ray department. I'd tell all my patients to make their choices based on what would feel right if they knew they were going to die in a day, a week, or a year. That's one way of giving people an immediate awareness of how they feel, even if they have never paid any attention to feelings. We don't have the luxury of 5 years of psychoanalysis when someone may not live that long. We have to begin change immediately. And the best way is by asking what you'd want to do with this short period of time. Individual reactions. The one crucial question is what approach will work for each person. Never underestimate the value of the truth, even if it's a shock. I remember a patient who was in congestive heart failure, not taking her medicine, smoking like a chimney, and then coming to me for a gallbladder operation. I asked her, "Did you come here to have me kill you?" The question surprised her, and she said, "Nobody has talked to me like that since I gave up psychotherapy." I just explained that before I could deal with her gallbladder, I had to deal with her depression and try to give her a reason for living. I recently saw a patient with a brain tumor that had already progressed to the point of causing seizures. She was trying to decide whether to have it surgically removed or treat it only with a nutritional program. A friend had asked her to talk to me since her regular doctors were all angry at her for shying away from aggressive treatment of this critical illness. I sat and talked with her until we got to the root of the problem, the fact that she was very depressed with no great desire to go on living. Therefore, it was easier for her to just change her diet a little. This would cause her no great discomfort, and if she died, it would be no great loss as far as she was concerned. My effort then was to show her how to make her life interesting enough to continue living. Then she would be in a position to choose modern techniques for dealing with the emergency, as well as to change her outlook thoroughly for the future. I recommend that patients do not reject standard medical techniques, at least as one option. Drugs and surgery buy time and may cure while patients work to change their lives. Soon after we'd set up ECAP, I was interviewed by the Midnight Globe tabloid. The resulting article was very fair and the quotations accurate, but I was upset by the headline, "Surgeon says mind can cure cancer." I thought it was simplistic and misleading. The more I worked with patients, however, the more I came to see that the statement was correct. Now I consider those omnipresent supermarket newspapers to be important medical journals. I say this tongue mostly in cheek. The mind can cure cancer, but that doesn't mean it's easy. The paradox is wonderfully expressed by an old Sufi story. A stranger comes upon a man on his hands and knees under a street lamp in front of his house. He's looking for his keys, and the stranger gets down on all fours to help him. After a time, the stranger asks, "Where exactly did you drop them?" "In my house," comes the reply. Exasperated, the stranger asks, "Then why are you looking out here?" "Because it's dark in the house." The light is better in our conscious minds, but we must look for healing in the dark unconscious. The doctor works in the light. He is verbal and logical. The patient's world may be dark, but there are sources of illumination. Within each of us is a spark. Call it a divine spark if you will, but it is there and can light the way to health. There are no incurable diseases, only incurable people.